Welcome everyone to today's Revive webinar from the Global Antibiotic Research and Development Partnership, GARDP. My name is Victor Kwasi, and I'll be hosting today's session on using artificial intelligence to analyze and predict susceptibility to antimicrobials. Revive is GARDP's education and outreach program. It aims to connect and support the antimicrobial R&D community by facilitating learning, connecting people, and sharing knowledge. These webinars are part of our educational activities. All of our webinars are recorded and are freely available to view after the live broadcast on our website, revive.gardp.org/webinars. You can also read our articles known as Antimicrobial Viewpoints, where experts in the field discuss various topics in AMR. And we also have a resources section, which includes the Antimicrobial Encyclopedia. This has definitions on various important terms in the field, some of which you'll hear in today's webinar. Some of these terms also have videos where experts give further explanations on the terms. As always, today's presentations will be followed by a Q&A session. You can submit your questions at any time during the webinar by clicking on the questions button as shown on the slide. We'll address the questions after the presentations and do our best to respond to as many as possible. If your question is for a specific speaker, please do indicate their name at the beginning of your question. So today's speakers are Adrian Egli and Javier Fernández Domínguez. Our moderator today is Margo Diricks. Margo Diricks is a bioengineer who completed her PhD in the field of biocatalysis at the University of Ghent in Belgium. After working there for 3 years at a bioinformatics company, she joined the research center Borstel, RCB, or the Leibniz Lung Center in Germany in 2020 as a postdoctoral researcher. At RCB, Margo focused on developing and applying bioinformatics tools and pipelines to analyze, interpret, and visualize genomic data of emerging drug-resistant lung pathogens such as non-tuberculous mycobacteria, and Haemophilus influenzae, and Streptococcus multifimia, in order to study their transmission dynamics and their evolution of AMR. Margo is also actively engaged in large-scale international collaborations and professional networks, including the Pan-African Network for Genomic Surveillance of Related Diseases and Emerging Pathogens, as well as the European Society for Microbiology. She's also editor for BMC Genomic Data and guest editor for a special collection of genomic biology that focuses on AMR. Welcome, Margo. I will now hand over to you to introduce our first speaker.
Yes, many thanks, Victor, for the kind introduction. I must say I'm pretty excited for today's webinar and looking forward to the 2 upcoming presentations. And our first speaker of today is Adrian Egli. So he's a director of the Institute of Medical Microbiology, University of Zürich, and his research aims include developing new diagnostics for rapid detection of multi-drug resistant and virulent pathogens, exploring novel typing technologies such as whole genome sequencing and MALDI-TOF for clinical applications, and to understand the evolution of pathogens within the host, for example, during antibiotic treatment. Between 2015 and 2022, Adrian was the head of clinical microbiology at the University Hospital of Basel in Switzerland, where he was also a fellow in clinical microbiology. He's also a research group leader in applied microbiology research in the Department of Biomedicine of the University of Basel. Adrian studied medicine at the University of Basel and also received his PhD from the same university in 2008. So now I'm happy to welcome Adrian. Adrian, the floor is yours.
Thank you. Thank you very much for the opportunity and also for the kind introduction. I will go to the first slide. Just a second. It's a bit lag here. I apologize. Okay, sorry for that. Without artificial intelligence, we are obviously lost. So thanks a lot for the opportunity again. I will talk with you about using AI to analyze susceptibility to antimicrobials, and to kind of bring everybody to the same level. I just would like to highlight briefly the problem. First of all, I think, you know, I'm a medical microbiologist, so I will address this problem from a diagnostic perspective. And obviously there are many different pathogens linked to antibiotic drug resistance. And I'm pretty sure you're familiar with this paper, which was published in the Lancet 2022, showing the 3 different infectious diseases caused by many different pathogens linked to antibiotic drug resistance. So for example, lower respiratory tract infection, bloodstream infection, and intra-abdominal infection together are estimated with close to 5 million deaths per year. So really a devastating situation. Now, from a molecular perspective, there's even more heterogeneity, because it's not just about the different infectious diseases, you know, with different sample types, different sensitivities and specificities relating to these sample types, but also bacteria and then the underlying molecular resistant mechanisms. So if you develop a system, an AI-based system which can capture these resistances, you need to make sure that you also capture the biological diversity beyond. And this paper from the New England Journal of Medicine is basically a classic. You see here a double membrane of a gram-negative bacteria. And as you know, there can be porin loss, there could be efflux pump activity, which you can see here, a target modification, or cleaving enzymes. And this heterogeneity to capture with a single diagnostic assay is not easy, I can tell you, because you need a huge amount of data to train. Now, so the consequence of this is a delay in antibiotic susceptibility testing. Especially if we have culture-based diagnostics, which is anyways slow, then due to this, as a consequence, empiric therapy is obviously very often quite broad, because you want to not have this situation which is shown here on the right side, where you have a septic shock situation, and you see here on the x-axis time since onset of hypotension. So this is basically septic shock, and you see how rapidly the survival fraction of the patients go down due to a lack of an effective antimicrobial situation. And so due to this reason, very often broad spectrum antibiotics are given to capture all sorts of eventualities, and this then results obviously in more selective pressure for the bacteria. So the question we want to ask ourselves here is, can we use artificial intelligence for a more rapid assessment and then a more targeted therapy? So what is artificial intelligence? I will keep this very short. You very often see now on the internet these kind of onion-like structures, where artificial intelligence is obviously an extremely broad term. So basically a human-like intelligence which allows you reasoning, learning, problem solving, and decision making. It sounds a bit too good to be true, to be honest, and maybe also a bit like a magic bullet. Especially we are used to now deep learning approaches. So for example, if you use ChatGPT, you're in this space, but there are many other applications like image recognition, etc., where you have more classical machine learning applications, which you will see from my side. So where is artificial intelligence really good in? Let's see if the next slide comes here. The slides are not moving. Oh, here. I hope it now doesn't move to the next one. So categorization is a very important aspect. And what you see here is a mixture of muffins and chihuahuas. And for obvious reasons, you want to separate them. And what you can do is you can use an AI algorithm to have nice labels attached to that. And that obviously works with a lot of data sets. You will see later on image analysis with a bit more domain-specific aspects on microbiology. The point is, for image analysis, you would use something like a convolutional neural network, so that would be the most suitable AI technique. But the problem is that these AI algorithms are often black box essays, so we do not really know what are the features which then allowed the AI to build these categories. And there's a new trend, which you see now in most of the papers, or in many papers, is so-called explainable AI. So there are techniques like SHAP analysis, where you see which feature contributed how much to the separation of the category. That's extremely helpful in also understanding and focusing, for example, on certain aspects. So that's number one, categorization. The next one is accessing information. And we have to be careful here. This is not knowledge, because AI often tricks us. And, you know, if you use, for example, a chatbot like ChatGPT or others, then they kind of say they are thinking, but at the end, it's not like active thinking like we do. It's more a probabilistic model of the next, you know, word which comes. But nevertheless, it's impressive how much information in a very short time period can be accessed. You see here on the x-axis a time scale, and on the y-axis you have the percent performance of the MEDQA. So that's the medical board exam of medical students. You see here that in March 2023, that's, I mean, yeah, more than 2 years ago, 2.5 years ago, it already had 86% correct, this particular model. And obviously nowadays it would be 98, 99%, so that's no problem to pass a medical board exam. So we also have to consider now a bit, you know, what defines a physician and what is important information. Now, this is obviously a very broad exam, very, I would also say maybe superficial. So it doesn't contain a lot of domain level expertise. So public health expertise, epidemiology, medical microbiology. There's not so much training data, most likely, which is present in these large language models. But these models get better and better also in domain level expertise. And you can also enrich them by, for example, sharing certain documents and then accessing them. But these are the two main points, so categorization and information access. Now, let's dig into the lab. So where can AI be implemented? And I think if we look at the diagnostic process from the patient and physician to the lab, you have first a pre-analytical period. There, for example, one can imagine to use diagnostic stewardship tools, quality assessment, and so on, maybe even assessments of pre-test probabilities. Then in the lab itself, you have lots of applications, microscopy, image analysis of agar plates, and so on. And then communicating the results back there, I also think it's a quite underestimated aspect of the lab. So to use AI for communication, for example, breaking down most important information, you know, in a very concise way, or explaining a complex lab result to a patient, that could also be used for. And this circle I like to call the brain-to-brain cycle. Okay, let's start with the analytics, because I think that's the most important part. So I'm waiting for the next image. It's really a bit a slow device here. Okay, now here is the image. So you see, this is the routine lab workflow from specimen to culture, multi-TOF resistance. And then you could obviously, the culture-based part, which might take several days to weeks, you can bypass by PCR or sequencing-based technology. And we will focus our part now on culture and image recognition. And the core technology which you need to know here are convolutional neural networks, as I've mentioned before. So you have an agar plate, you can digitalize this agar plate as an image, and then you can analyze different features from this agar plate. So you could, for example, say, are there bacterial colonies on the agar plate, yes or no? What how does the colony look like, what color does it have, what shape, etc. All these features are extracted and then enter a neural network. And if you have the ground truth, if this is known, so for example, in this case, it would be pink colonies on a McConkey plate, you could say, okay, this is an E. coli. And what the system will do in the neural network, it will increase and strengthen the connections, for example, for pink color or a certain shape of the colony. And then it ends up with the, likely identification of Escherichia coli. This works very well already in commercial systems. Oops, it went one too far. I have to go back one slide. Okay, here. So this works very well for detection of colonies. So for example, is there growth or no growth? You can see here very high sensitivities and specificities. And these are papers which are, almost 10 years old. So that's not new AI. So that's really old techniques. What is relatively new is with certain chromogenic agar plates, you can now also identify the species which is on the plate. So for example, as I mentioned before, a McConkey plate, or here a urogenic chrome agar plate, if there's a pink colony, you can, with a very high confidentiality, say this is an Escherichia coli. And there's a very nice paper for those of you who are interested in this, published in Nature Communication 2023 from colleagues from Italy. And they showed here very nice performance. Now, this also works for reading inhibition zones when you use Kirby-Bauer as a disk diffusion method. So here you see two different bacteria, Pseudomonas aeruginosa and Escherichia coli. Each column here, I apologize here that the graph is not sharp, but each column here is the same bacteria measured over and over again, in total 12 times. And you see here, every colored line is an antibiotic and how much millimeter inhibition zone was measured. And what you notice that it's extremely stable with a few exceptions. There are 5 outliers which you can see, but the measurement overall is within the margin of ±1 millimeter. So that's an extremely precise measurement. And the authors conclude here, maybe in the future, the categorical interpretation of this can be reported without requiring a human check. At the moment, I would clearly advise against this. I would double check it, but I think it's very nice. Now, what we try to do, it's really jumping here a bit back and forth. I really apologize for this tool here. I want to go back one slide. Okay, good, thank you. So what we asked ourselves is, would ChatGPT be able to also read such images? And we generated something we call the UCAST GPT expert. So basically we shared with ChatGPT different documents like expert rules of UCAST, etc. So it became really aware of the like, what is UCAST and the rules behind it, etc., and the breakpoints. And then we shared with it images like these. So you see here colored circles, and they show the inhibition zone. We also provided the inhibition as a table and the original image without the colored circle. So basically the same information the human had. And we then asked it 225 times. So we showed 225 different images. What is the underlying resistance mechanism? Is this an ESBL, an AMP-C, or a carbapenemase producer? So the first thing we did is we asked human experts. You can see here on the left side. So the human experts, they had a high sensitivity and specificity for ESBL, AMP-C, and carbapenemases, which you can see here on the table, always around 96, 97%, 98, 99%. So that's good. 3 human experts were asked to independently assess the pictures. Now, when you use the GPT expert, you can see that the sensitivities are also very nice, 95%, 96, even 100%, but the specificity is low. So ESBL, it too often said there's an ESBL despite the fact that there was none. And when you ask ChatGPT also several times, you do that 3 times, it sometimes also gives you a different response. And that's also quite interesting, I have to say. But at the end, it's a probabilistic model. It predicts the next likely word. So there, you know, one can imagine that there is some variability in there. So obviously, we would not use this as a diagnostic tool, but I think it's quite interesting to see what is the capability of a system where everybody on the planet basically has access to. Now let me go to the next slide. Okay, so what you can also use is an image device with a smartphone. So there's a very nice tool which is free and which you can access over Médecins Sans Frontières, and this could help you in your lab, and it's basically a portable AI system. So that also exists. And now I want to focus on MultiTOF, because here also AI can be very strong, and I think there's a lot of research ongoing. So we were wondering if AMR profiles can be directly predicted from a MultiTOF profile. And you see here 2 students at that time, PhD students, and they generated this project together with other colleagues from different hospitals. And we generated a very large data set where we took 300,000 MultiTOF spectra and we linked them with Vitek2 results. That was what we had available in the routine lab. And there were 4 different hospitals, and therefore we had 4 different databases with this, you know, spectra and the matching antibiotic resistance profile. And then we had to harmonize the different MultiTOF spectra, so there was some data cleaning. We also then generated a vector, so basically the spectrum was in a vector linked with the respective antibiotic drug resistance profile, and we used 3 different machine learning techniques to kind of analyze and learn this. And the results here are not perfect, clearly not. When you look at the area under the receiver operating curve, which is, you know, a combination of sensitivity and specificity, and you're probably aware that 0.5 would be flipping a coin, you see it's much better than flipping a coin, but it's not, you know, 90% or 95%. So for oxacillin resistance prediction, which would be MRSA, in our case it's 0.8. For ceftriaxone resistant, and in my hospital at that time, it was clearly ESBL, it was 0.74. But what happened since then, because we released the data set, multiple studies have confirmed the findings, and more importantly, they have also improved our algorithms. So there was a very nice transformer model published at the beginning of this year, which basically uses a large language model to analyze the MultiTOF spectra, and there you reach area under the receiver operating curves of 0.9, 0.95. So there it's very, very nice. Now, let me go to the next slide. So the conclusion of this first part is that time is critical for adequate and efficient antibiotic treatment. Traditional culture-based diagnostic takes time. Resistance mechanisms are diverse. And I think AI has a huge potential here, obviously. Large language models can be used in a very broad sense, not just for, you know, getting information, but also helping you to interpret certain things. Smartphone-based apps might be something which is very suitable for low and middle income countries, and more sophisticated use is possible. For example, this MultiTOF use case you've seen, but you need an extremely large data set to do that. And what we should always remind is you need a step-by-step validation, consider ethical aspects, legal aspects, and regulatory aspects, and we should also be critical. Now, I just want to, I'm not sure how I am in the time, but I have 2 more slides which I would like to share with you. But it's really not moving forward. This here. Okay, so what comes next? I think the question is for us also, how do we prepare ourselves for this? And in the past, we defined ourselves extremely over cognitive knowledge. I mean, that's what an expert is. You have read many books, you have seen many cases. This is what an expert is. You were perhaps also very skilled in the lab, and you had a good observation skill because you could recognize patterns, etc. But now, at time of AI, this has to change, because obviously accessing information is very easy, as I've shown you. Observation skills against the convolutional neural network is very hard, I can tell you. We do some comparisons here with our lab technicians, and AI usually wins. So you need a different skill set, and you need to prepare for that. And I think it's very, very important that we adapt our curricula, because I'm pretty sure in 10 years, we cannot define ourselves only by your knowledge. We need to really adapt to this. And for this, there are obviously a lot of regulatory aspects. In the EU, we have the IVDR, the AI Act, etc. So everything is quite regulated, and that's maybe also a danger, I have to say, because most of the AI innovation is not happening in Europe, unfortunately. And perhaps this also is a challenge for innovation, and especially smaller startup companies if they want to progress diagnostic tools. So how can we generate an environment in Europe where diagnostic is valued and it's not killed by a regulatory burden? So that's maybe something for the discussion. And with this, I'm at the end of my talk. Okay, it's again not moving. I'm very sorry. I'm really apologizing for this slow-moving tool. The key message is, key challenges in AMR are knowledge and speed. Image analyzing is a low-hanging fruit. Multitoph is a high-hanging fruit, but there's huge progress due to new types of AI. Everything outside of the lab, including patient data, is currently a tightly regulated space. So I think in the lab with analytical parts, there can be done something, and the usage of AI should be critically evaluated. And on the last slide, I have some contact. So please follow me on LinkedIn and contact me if you have questions. Thank you very much.
Thank you very much, Adrian, for this really great presentation. So we will immediately move over now to our next speaker, because questions will only be addressed after the next speaker's presentation. So the next speaker of today is Javier Fernández Domínguez. So he is a co-founder and co-CEO at Pragmatech AI Solutions. This is a startup whose main product is IAST, an AI-based software platform for antibiotic prescribing support that has obtained the CE certification, becoming the first software of its kind to achieve this milestone. So Javier is a specialist in clinical microbiology with extensive experience in antibiotic resistance and applying innovation in artificial intelligence to infectious diseases. And between 2016 and 2025, he led the antibiotic susceptibility testing section at the Central University Hospital of Asturias, was a founding member of the hospital's antimicrobial stewardship team, and served as principal investigator in antimicrobial resistance research within the translational microbiology group at the Health Research Institute of the Principality of Asturias. He was also previously an adjunct professor at the University of Oviedo in Spain between 2022 and 2025. Javier holds a degree in pharmacy from the Complutense University of Madrid. He specialized in clinical microbiology at UHCA and earned his PhD from the University of Oviedo. He has sat on the editorial boards of national and international journals, published over 80 scientific articles, and has received several research awards, including 2 PRON awards granted by the Spanish Agency of Medicines and the Ministry of Health. So with that, I can now hand over to Javier. Javier, please, the floor is yours.
Okay, so thank you very much for the introduction, Margo, and thank you, Adrian, for your excellent presentation. It's a pleasure to be here this afternoon. Thanks also to Revive for inviting me to this interesting webinar. So I would like to pass the slides. Okay, so I'm going to talk of the use of artificial intelligence to analyze and to predict susceptibility to antimicrobials, but from another point of view. We analyze cumulative antibiograms, phenotypic data to predict resistance in further patients who are admitted in hospitals. I'm clinical microbiologist. I work for a long time in hospitals, but from June of this year, I work in full dedication to Pragmatech. So first of all, something that also Adrian has liked before, the challenge of antibiotic resistance. Now, this is one of the biggest problems for the healthcare systems worldwide, and it's costing a lot of lives, but also a lot of money to the healthcare systems. And the worst is that the forecasts for the future are pessimistic. No, according to this work published by the World Health Organization, by the year 2050, it could be in the world more than 10 million deaths attributable to antibiotic resistance, and this is going to cost a lot of money to the healthcare systems in the different countries. No, in fact, some studies say that it could cost between the 2 and the 3% of the gross domestic product. This is something that probably all of the people that are here well know, no? But what sometimes we forget is that a third of the antibiotic prescription at this moment are wrong. And are wrong not only because the dose is not the correct, the duration of the therapy is not the correct, they are wrong because they don't cover the microorganism that is infecting the patient. No? It's growing in the cultures of the patients. This leads to an increase of the mortality and poor outcome of the infection. It increases the hospital stays, increase the associated costs of the healthcare of the patients, and also increase readmissions of the patient in the hospitals. No? So this figure of the 30% of mistakes is something that has been published in several words. We can see 100 or 1,000 of words in which they say that a third of antibiotic prescription are wrong. I can pass the slide, sorry. Now it's okay. So we can see in different settings. No, first in the ambulatory care, in primary care, these mistakes are very frequent. Also in hospital, in patients admitted in hospitals, but even in patients admitted in intensive care units, these mistakes are very frequent. This is strange, no? Because the patients admitted in intensive care medicine are the patients that are more surveillance. But in this study published 2 years ago, the Europac published in intensive care medicine, they measure what happened with the therapy, the antibiotic therapy, with the time. The time was passing when a blistering infection was suspected. No, at the beginning, when the doctors suspect a blistering infection and they don't have microbiological results, the rate of covering of the microorganism that is going to growth in the culture is around 40% in the first moment, and when the blood culture is sampling. No? If the bacteria is resistant, this rate is around 22%. There is a 22% of accuracy. This percentage of accuracy is growing, but even when we have microbiological results in the 4th day, when most of the laboratories have results, the percentage of success of covering the microorganism infecting the patient is only 82%, and even lower if the microorganism is difficult to treat or multi-drug resistant. This is something that probably in the year 2025 we shouldn't admit, no? Because it's a huge problem for the health of the patients. I try to analyze the causes of the errors in antibiotic therapy, and I detected there are much more, no? But I'm going to talk about 4 topics that are related with errors in antibiotic therapy. First is something that Dr. Adrian has talked before, delayed microbiological results. Normally, the laboratories working in bacteriology perform cultures. And if we perform culture, we have to wait that the bacteria grows. And then to perform antibiotic susceptibility testing, we have to wait another 48 hours or 72 hours to have a result. It's true that in the last year, several techniques have been incorporated in clinical microbiological labs. So we have faster results. For example, we have some kind of rapid phenotypic AST, some types of genotypic AST. But the truth is that the reality is that now probably these kind of techniques are used only for a selection of patients. No? For example, patients admitted in intensive care units, patients with bloodstream infection. And the reality is that these rapid antibiograms only represent a few percentage or a low percentage of the result of a clinical of the results of the clinical microbiology laboratories. No? So this is probably one of the causes of the errors in the antibiotic therapy at the first moment of infection suspicion. Then also clinical microbiologists, we work every year or every year in making cumulative antibiograms reports, which I think that they are very important. In fact, we published some years ago in Clinical Infectious Diseases an article highlighting the importance of this kind of cumulative antibiograms for diagnostic stewardship and also for antimicrobial stewardship. No? It's true that they provide very useful information, but also it's true that they provide limited information. Why? Because normally we perform this kind of reports once per year. Also, we only include the first isolate of a patient. So if, for example, a patient is admitted in a hospital and has several episodes of infections, this guide or this map can't allow the doctor to select the antimicrobial. No? If it's an infection that has a patient and it's the first infection of the patient in the hospital, probably this kind of reports can help to choose the empirical therapy, but for other situations, no. And there's another thing that is important to highlight, and is that these kind of reports are well known among clinical microbiologists and infectious disease physicians, but not well known among prescribers. No? Then we have another causes of mistakes in antibiotic therapy. Sorry, I'm trying to pass the slide. Okay, so also we have some limitation with the evidence-based medicine in infectious diseases. It's true that the evidence-based medicine has made us to advance a lot in the treatment of infections and any kind of pathology, but it has some limitation, no? And especially in the field of infectious diseases. First, the inclusion and exclusion criteria leave out certain population, and they are very important population because they are sometimes the more difficult to treat population, like patients in intensive care unit, in pediatrics wards, pregnant women, etc. No? Also, we know that the results of the clinical trials and the guidelines are applicable to population, but not to individuals, and sometimes some individuals are not benefit from the recommendation of the guidelines. No? And there's another point is that in infectious diseases we have a lot of uncontrolled variables. No, because normally when we treat a disease we have the patient and the disease, but here we have also the microorganism, and we have thousands of potential pathogens with their virulence, resistance. So it's very difficult to have evidence for each situation, for each pathogen with each mechanism of resistance, etc. No? So this is another limitation and another thing that could make errors in antibiotic therapy. And then also there's something inherent to the human, which is, sorry, I can pass the slide. Yes, which are the errors in medical judgments. We know that the medicine is a mix between science and art, and like all the arts, it depends, the success, it depends of the knowledge and also the inspiration. No? When we treat an infection or when we treat any disease, we have to take into account the probability. In this case, the probability that the bacteria is going to be susceptible or resistant. Sorry, but the slide, it doesn't work, the pass goes slow. Now it's okay. So we have a high degree of empiricism. No, we have to manage the probability of the the bacteria to be resistant or susceptible. But we also commit biases, and this is normal because, for example, in my hospital, some years ago, 15 years ago, we used ciprofloxacin to the urinary tract infection because there was no resistance. It was a very good drug. But now, with the pass of the time, we have a lot of resistance. But if we have the knowledge of the past, we have commit the bias of prescribing quinolone to urinary tract infection because we always perform in this way, and we think that is still working. No? And we also are conditioned by the noise, the random mistakes. It depends of the state of the day. It depends of several factors that we make a decision prescribing an antibiotic. And here in the next slide, we can see an example. Okay, so in this article, very interesting, published in JAMA some years ago, they studied the influence of the time of the day and the decision to prescribe antibiotics. If we see in the bottom, they represent how percentage of patients are treated with antibiotics in those cases in which these antibiotics are not indicated, no? For example, in a flu. So we see this percentage of antibiotic prescribing is increasing with the time and with the fatigue of the doctors. No? Also, if we see in the top of the graph, we can see in those cases in which sometimes antibiotic is recommended or no, it's not clear, like otitis, for example, or sinusitis, how the doctors, in the way they are more fatigued, more tired, they prescribe more antibiotics. No, so we are influenced by the random mistakes, no, and the noise. So it's for that that all these things could be improved with the use of artificial intelligence. No, artificial intelligence. We think we have been making research in this topic for a long time that can help to predict antibiotic susceptibility and to help antibiotic prescription. Why? First of all, because it allows to microbiological results to be anticipated and predicted. No? Using a lot of data about antibiotics, we can predict and anticipate antibiotic resistance. Also, it allows to make the recommendation adapted to the local ecological data, no? To the local epidemiology of the different hospitals, because as you know, the epidemiology of resistance in different centers are totally different. No? Even in the same center is very different, the epidemiology of resistance from one hospital ward to another. So also it allows combine evidence-based medicine with a personalized approach. No? It can make recommendation not for population but for individuals, and also it can reduce bias and noise. There are a lot of literature about artificial intelligence, and one of the points that highlight this literature is that it reduces bias and noise if this artificial intelligence is well trained. So, in the last year, sorry, I can pass the slide again. Let's go a bit slow. Now. So, Adrian has talked about this before. I'm going to pass very, very fast, but only I would like to highlight that there are a lot of kinds of artificial intelligence, no? But in medicine, and specifically in the field of antimicrobial susceptibility prediction, there are a lot of research groups that have been working with machine learning. Machine learning are statistical techniques, advanced statistical techniques that can process a high amount of data, and from this data they can detect some patterns, and from this pattern they can extrapolate some results. No? So in the last year there has been a lot of research groups that have been working in prediction antibiotic resistance using machine learning techniques. In the next slide, we have some example, a revision of 2 years ago, in which they analyze the papers or the research work that have been applying different machine learning techniques to predict antibiotic resistance. Most of these works have been applied to specific microorganisms like E. coli, Klebsiella pneumoniae. They have been applied to predict if these microorganisms are going to be multi-drug resistant or not. They are applied, for example, for specifically urinary tract infection or bloodstream infections. No, and the performance evaluation metrics are not bad, but are not probably ready to use in clinical practice, no, because this area under cube operating log curves, no, are between 0.7, 0.8, so probably they are not ready for clinical practice, but they are promising and interesting. In Pragmatech, we have been working in this topic for 4 or 5 years, and we have developed an algorithm that is capable of predict antibiotic resistance. This algorithm has been converted in a product, in a software, and then this software is certified. We have the CE mark. And what we did is to integrate data from scientific literature. During a lot of time, we have created our databases with data of different pathogens from scientific literature regarding resistance, phenotypic antimicrobial resistance. No? So we have a very important, a very big database with information about resistance from public databases and scientific literature. Also, we integrate some data from patients, also some data, a lot of data from therapeutic guidelines, because the recommendation that our software gives have to be aligned with therapeutic guidelines, with international, national, and also local guidelines. And probably the most important is that we train or we fine-tune the model with data from local epidemiology and resistance. Okay, in every deployment, we train or we fine-tune the model with data from antibiograms from the hospital. And the aim of the software is to provide aid for doctors and physicians in the choice of the empirical therapy, also for the semi-targeted therapy. Once we have a microorganism identified, but we don't have its antimicrobial susceptibility results, the software also provides information. And also we cross final microbiological results with therapies, and we give alerts to physicians when a microorganism is not covered by the antibiotic that is prescribed by the doctor, once we have the final microbiological results. As I told you before, this is a medical device, so it's regulated by the MDR, the law, the European law of medical devices. It's a class 2A product, medical device, and we have the CE mark from July of this year. I'm trying to pass again the slide, but it goes very slow, very slow. So this is a medical device, so we have to demonstrate its accuracy, its effectiveness, and also its safety before to commercialize. It's for that we carry out a clinical trials. We perform a clinical trial in 12 hospitals in Spain. This clinical trials was led by José Barberán, who is a very important infectious diseases doctor here in Spain. And thanks to this project, this evaluation, and this product, we received the last year the award of the best initiative for surveillance and control of antibiotic consumption and resistance in the field of human health, which was given by the Minister of Health of Spain. What we did in this study is what we do in every deployment of the software in every hospital, and is the next. Sorry, it goes slowly. Okay. So first, we extract data from antibiograms from patients who were admitted in the hospital in the year before. We extract an amount of around 27,000 antibiograms. We perform a cross-validation, and we use some data from training data set, some data from validation, and then we perform a testing. And once the model was validated from the mathematical point of view, we put the software into production. And the clinical investigators recruit 325 patients. They review what antibiotic has been prescribed by the doctor. Then they simulate the cases with our software IAS, and they compare the 3 first recommendations of the software, because our software doesn't give a unique drug recommended to the doctor. It gives a ranking of antibiotics ordered by the probability of success. So they compare the 3 first recommendations of the software and the antibiotic prescription by the doctor with the final antibiogram result. And the endpoint of the first endpoint of the study was demonstrate that the software was not inferior to the doctors in covering the microorganisms infecting the patient. The results are here in the next slide. Sorry. Okay, so these were the metrics obtained in the model. We have very good values of precision, recall, sensitivity, and log loss, both in the validation and the testing data set. So these are the metrics measured in the mathematical validation. And then the patients that were included in the study, the summary of these patients are represented in the next table. Sorry. Which is here, okay? So 60% of the patients were hospitalized in hospital wards, but we have a 37% of patients who were outpatients. Okay, the software gives recommendation for patients admitted in hospital, but also for outpatients. Then most of the patients admitted in hospitals were admitted in internal medicine or infectious disease ward, and also in intensive care units. Okay, and then the recommendation that the patients included were have different kind of infection. Most of them have bacteremia, urinary tract infection, nosocomial lower respiratory infection, and also other kind of infections such as bone and joint infection, gastrointestinal infection, etc. So in the next slide, here we can see that the software was able to reduce medical errors in empirical therapy from 31.1% to 8.9%. Here in the table, you can see the results detailed by specific infection. Here in orange, we can see the percent of accuracy of the doctor, 69.9 for bacteremia, 76.7 for urinary tract infection, or 59% for pneumonia. And here below, you can see the percentage of accuracy of the software. No? The first recommendation of the software, the second and the third, they always have an accuracy higher than 90%, no? 93%, etc. Here in the bottom of the graph, you can see the accuracy of the doctor once the microbiological, the bacteria is identified, but we don't have results of antimicrobial susceptibility testing. So this rate of success in the doctors increased to 83% in bacteremia, 89% in urinary tract infection, and 73% in pneumonia. But the accuracy of the software, when it knows the bacteria that is infecting the patient, but not its specific antimicrobial susceptibility profile, the rate of success are higher than 95%, no? Even close to 100% in many cases. So probably most of the people, or some people, you are thinking that it's not, sorry, I passed 2 slides, I go back. Probably you are thinking that it's very easy to give the good recommendation if the software always recommend broad spectrum antimicrobial, no? But in the design of the software, we always take into account the antimicrobial stewardship. So we try to make recommendation of drugs that cover the microorganism that is infecting the patient, but using antimicrobials of narrow spectrum. In fact, the secondary endpoint of the study was demonstrate that our software was able to reduce the recommendation of watch antibiotics and increase the recommendation of antibiotics of the group access. In the left, you can see that most of the physicians in empirical therapy, they use watch antibiotics, and our software is able to be accurately, but using or recommending antibiotics or lower spectrum. No? So I'm finishing. I have 2 more slides only. So now this software has different features. It guides empirical antibiotic therapy when it's connected to medical records, for example, or laboratory information system. Also, it can guide semi-targeted antibiotic therapy. Also, we have the module of prescription alerts. And also, we allow clinical microbiologists to make cumulative antimicrobial susceptibility testing reports and incidence density multi-drug resistant bacteria reports. And also we help to antimicrobial stewardship teams and pharmacy services to monitoring drug consumption, no? Through DDDs and DODs. So my conclusions, and this is the last slide, are the next, sorry. So the mathematical performance metrics of the AIS model have exhibited robust values, surpassing those of any other published algorithms to date. Clinical research conducted have demonstrated that AIAs can significantly mitigate physician errors in empirical and semi-targeted antibiotic therapy while concurrently fostering antimicrobial stewardship. That reducing errors in early antibiotic therapy holds the potential for enhanced infection outcomes, cost savings within healthcare system and combating antibiotic resistance, and that further prospective studies are warranted to corroborate AIA's performance across diverse epidemiological settings and to quantitatively assess its benefits. So thank you very much. Here in the next slide, you have a QR to my LinkedIn profile. So if you have any question, I'm happy to answer you. Thank you. Thank you very much.
Okay, thank you very much, Javier. We will now start the question and answer session. So as a quick reminder for the audience, you can submit your questions as shown on this slide. We will do our best to respond to as many questions as possible during the allocated time. So I will start with the very first question. So there is somebody that makes a comment that one of the main challenges with AI models is their black box nature, which has been mentioned by Adrian before, which makes it difficult to understand how decisions are made. What would you recommend as an effective approach to address this issue?
And maybe I can start with this. I think it's very important that we, thoroughly test every new diagnostic tool. I mean, we would also do this with any classical biomarker, to be honest. If you have now a new molecular test or whatsoever, you would also test this extensively. And the same is true for an AI-based tool. I can understand that some of the statistics might be really hard to follow and understand. And what I think in commercial essays, when you use now an AI-based tool, I think most of us would actually go for a commercial essay. And there, I think it will be very hard, also due to IP aspects, etc., to kind of get insights behind, let's say, the curtain. I think it's then part of a good software tool, which shows you, for example, the critical steps and, which factors and variables were important to kind of draw a conclusion. If you do in-house developed essays, I think this is anyways simply at the moment in the regulatory aspect of the EU, a pure research endeavor. Because as an academic institution, for example, my institute, we do a lot of AI development and tool development, but we cannot really apply this in routine diagnostics. It's always as part of a research study due to the IVDR. And I think then you don't have this issue because you will, you have data scientists in your team and so on. So sorry for the long answer, but I think at the end it's a commercial essay, and in a commercial essay, I hope the software will explain you some parts.
Yes, for example, in our case, if you are going to commercialize an artificial intelligence solution, they ask you that the solution has to be explicable, no? So in our case, for example, we know what are the variables that influence antibiotic resistance that have weight in the model to have the predictions. Probably there are other kind of artificial intelligence model like image processing algorithms that are more difficult to understand. But in our case, we know exactly where are the variables that influence in the decision of the software to predict and to recommend an antibiotic. And we know the specific weight of the different variables in the model. So it depends of the case of use, but when you apply machine learning and not very complex algorithms of deep learning, for example, it's more easy to explain the algorithms and to avoid the black box.
Thanks. I hope that answered the first question. The second question is from somebody from Cotonou. And he or she is asking if when the output of the AI tool is not exactly the same, for example, 3 inquiries and 3 different answers, is there any hint to choose an objective and accurate output?
I like that question. And I think, you know, it's like if you ask different doctors, they also have different opinions. So I guess there's no, you know, overarching. I wonder why we have this wish for absolute truth, you know, a tool which is always right. I think indeed, it is remarkable how some of the large language models are different. So we did a comparison of this, actually. We compared 6 different large language models with 30 pre-analytical questions. And it's sometimes quite nice how they diverse and how the quality of the output is. And again, I think it's really about validation. And in the end, in the clinical situation or in the diagnostic situation, you will have one tool which is validated. So if you then go and you ask ChatGPT in parallel and it gives you a different answer, then you have to ask yourself which one is the validated tool. So I would go for this.
It's not easy to commercialize an artificial intelligence solution based on generative artificial intelligence because the solution for having the CE mark has to be reproducible and also deterministic. So you know well that if you ask to an artificial intelligence, a generative artificial intelligence, a question, and then we ask the same question the day before or the next day, the answer can be totally different. No? So it's not easy for the CE mark to have this kind of products because in our case, for example, they tell us that our product had to be reproducible and deterministic. Something that is not easy with generative AI.
Maybe I can go on that. Do you have the feeling that this often happens in the AI solutions that are currently available? Because indeed, if you sometimes ask ChatGPT, he gives you an answer that sounds very reasonable, but when you then tell him, I don't think it's right, then he starts changing his or her answer completely. So is that something you have seen before with the AI solutions you are currently using?
Many times, actually. I mean, on a daily basis, I would say. The problem is always, do you have the expertise to judge the answer? But then if you know the answer, why do you ask an AI? And that's really an issue. So and that was one of the findings we had when we had these 6 different large language models I mentioned before. We asked medical experts to actually judge the accuracy and the completeness of the answer. And the lower the education level, so for example, medical students or physicians in training, they gave much better marks for the quality of the answer of the AI than more senior experts, which were much more critical. So I think we are all fooled on a daily basis. The question is just, you know, how well do we read the news or the output of the AI? I think this is a huge issue for sure.
Yes, I think that is dangerous. For example, those artificial intelligence that are aimed to be used for patients, no, directly from patients. That's a problem, no, because probably a bad result of artificial intelligence that can see, for example, a doctor, he's going to be interpreted, no, and he's going to say this had sense or had no sense. But this solution that goes directly to patients, I think that they are very, very dangerous.
Okay, thank you very much. The next question, Adrian, is from one of your mentees, Mohamed Daman, who wants to thank you for your hard work, but also has a question. So how do you think to increase the representativeness of images from different countries versus different bacterial isolates?
Yes, so that's thanks a lot for the very nice question. So the point is the bias we have in data sets we access. I mean, I would say 80% of the data which we use, so if you take whole genome sequencing data, image data, any lab-related data comes from high-income countries. And I would even say so US and perhaps some European countries which have very progressive data sharing policies. But if you train a system on data you access, and as soon as you see, for example, patients from another a country, let's say, where you don't have training data sets, this is a challenge for the system. And that holds also true for bacteria. So if you think about the genomic diversity, for example, how well is this reflected? Now, certain areas are certainly better, like tuberculosis, for example, but I'm pretty sure there are also many gaps. I mean, in terms of what do we sequence and where do we have access to data? So always be aware of the bias which a data set has. You should always ask that yourself.
Okay, perfect. Thank you.
Adrian, sorry, I have a question to you because it's interesting the part of MALDI-TOF. I would like to know if you work with the whole spectrum of MALDI or only with some regions which are related with resistance.
No, we work with the full spectrum from 2,000 to 20,000 Dalton. There, by the way, we have the same biases. There are 4 or 5 public data repositories, and they are all from Europe. There's no public data repository from the US, from Africa, from India, or from Asia. So I think this is a huge issue. At the moment, lots of the data sets are from Europe. Yeah, and we use the full spectrum, so we are not focusing on certain areas. Yeah.
So when you detect, for example, a resistant bacteria, or you predict with the artificial intelligence algorithm that the bacteria is going to be resistant, you think that is because you are detecting the mechanism of resistance in the protein profile, or you are detecting some clones which are related with resistance?
Most likely clones, because the resistance mechanism, so if you take, for example, an enzyme, has a much larger molecular weight, so that would be around 35,000 Dalton, whereas the spectrum is 2,000 to 20,000 Dalton. There are new techniques which can increase normal MALDI-TOFs. You can measure up to 70,000 Dalton if you use different matrices, but that's not commonly done in routine labs.
Okay.
Maybe to go forward on that, so that also means that, for example, mutational resistance is probably very difficult to detect with MALDI-TOF. I'm not sure what the latest status is there. For example, in TB, you only have mutational resistance, and as far as I know, that is not really well detected with MALDI-TOF.
Yeah, I would also say so. As mentioned before, if you have a point mutation, for example, causing an amino acid change, if the amino acid change results in a shift in the spectrum because, for example, the amino acid is significantly more lighter or heavier, then you could potentially see a shift in the spectrum. Enzymes like larger proteins, for example, as I mentioned, they are too large, you will not see them. So it's a lot about phylogenetic treats, and that also means that you need, if you have a MALDI-TOF based AI recognition system, you need to retrain every couple of years because of adaptations and changes in your epidemiology. This is why I think MALDI-TOF and AMR prediction is a high-hanging fruit, nothing which is very easily establishable in a lab.
In the case of Staph aureus resistant to methicillin, there are a module in the Bruker MALDI-TOF that can detect if the strain is resistant or not, but it doesn't work very well. And I think that is because it doesn't detect the mutation in the MEK-A gene. It detects some clones that are related to the methicillin resistant, and has been trained with probably with American strains, because in Europe, or at least in Spain, it doesn't work very well because it detects some clones that are related with methicillin resistant in the United States, not in Europe.
Absolutely, I agree with you. There are specific peaks which are linked to certain clonal complexes or even sequence types. So there's a specific peak for sequence type 131, for example. What is very nice, and we have just submitted this, there are sometimes not directly the resistance mechanism, but on the plasmid where the resistance mechanism is, there can be smaller proteins which are always present on a specific plasmid. And then you can have indirect evidence that the plasmid is there. And this then also correlates, for example, to a beta-lactamase, which is present on it.
And do you have experience, Adrian, with hydrolysis of antibiotics measured by MALDI?
We have never done this. I mean, I think it's quite manually intensive, and this is also a technique which I think not many labs are using. Yeah.
Mm-hmm. Yes.
Okay, I think we will move on to the next questions. There are still a couple in the chat. So for both speakers, a question: do AI models treat horizontally and vertically transmitted drug resistance the same?
I'm not sure what the basis of this question is. I mean, if you have, let's say you have a genome or a set of genomes, and you would train a system which recognizes a certain phenotype or could predict a certain phenotype from a genome. I'm not sure. I'm not sure if I understand the question, to be honest. Can this be specified?
I didn't understand the question, sorry.
So the question was if AI models treat horizontally and vertically acquired resistance different.
Probably they mean that if there are some model that can distinguish if the resistance has been acquired by, for example, mobile elements like plasmids or something like this, or has been transmitted vertically. So probably if there are some models that predict from genomes some resistance, probably these models can differ if the resistance is codified by a mutation or by a mobile plasmid, for example. No, I don't know if it's.
Yeah. But you know, at the end, it always depends on your data set. So if you have sufficient horizontal and sufficient vertical data sets available in your data set, then I think what you could look for is if you want to compare these two, you can go and check, for example, the metrics, the output basically of the model. You know, how is the area under the receiver curve, or how is the area under the precision recall curve, all these kind of matrices, and then you can see if there are differences in the performance, for example.
Yeah. Okay, the next question is, how can we demonstrate that the use of AI can be productive for underdeveloped countries or for the world? And related to that also, how can we minimize the error in AI predictions?
Mm-hmm. Yeah, I mean, I can start. I think the proof that something has a value requires prospective randomized trials. That would be the gold standard for me. Like if you do any intervention in medicine, if it's a new diagnostic test or a therapy, you would want to randomize two cohorts. One gets the AI, one doesn't get the IA, and then you would see what is the outcome and what is the benefit for the patient. The problem at the moment is that AI is such a hyped topic that first of all, there are almost more reviews than actual papers. That gets better, I think. But on the other hand, we also have 95% of the papers are retrospective. So you do not have like a real world situation where you can assess it. And I think then it really depends of, you know, the economic benefit. What is the economic benefit for you in your specific healthcare system? Because if you have a tool which predicts, for example, AMR, and you're in a low endemic situation or in a high endemic situation, it really might make a completely different performance for, you know, for example, reducing ICU admission or things like that. And then I think we need financial done studies. This is a general trend at the moment in diagnostics, I would say, valued-based medicine, so that you, and valued-based diagnostics. So if you do a test, does it actually have a value for the patient, for the healthcare provider, for the health insurance company, for example? And for this, you need to really have health economic experts doing studies together with you. So that's not an easy one. And I'm a bit, you know, the problem with high-income countries and low-income countries, sorry that I have here a lengthy reply, but I think there's really a problem with AI, that high-income countries have a lot of investment into AI, and there's an equity challenge, clearly, because you know, as I mentioned before, all the data is in high-income countries, so they train their systems. And so low-income countries would also need to have data access to actually train this, and it's not so easy for them to generate such stable AI systems. Yeah.
Yes, I think that probably as Adrian told before, the problem in low-income countries is that we don't have data, no? So if we don't have data, for example, about resistance, it's difficult to make a model to predict what is the best antibiotic for patient in these kind of countries, no? It's true that, for example, at the level of infrastructure or hardware, now there are some artificial intelligence like machine learning techniques that they don't need a very top computers, no? So here I can see a problem in this way, but the problem is the data, the lack of data. However, I think that, for example, in countries where they don't have clinical microbiological labs in all the hospitals, this kind of solutions could be very useful, but it's difficult to adapt this kind of algorithms to data from these countries because, as I told you before, we don't have data.
Thanks for the
What's the
answer.
second part of the question?
That was how can we minimize errors in AI output?
Yeah, I mean, it's large data sets, and I think proper validation, looking for diverse data sets, not just data sets from Switzerland, for example, or from the US, I guess. Look, I bring you one example. Most of the sepsis research is based on the MIMIC data set. The MIMIC data set is a sepsis related data set in the US, and I would say 90% of the publications are using one single data set. This is really not good. We need larger data sets from other countries regarding sepsis to also validate. And if you have an AI system, go to another country, like an truly external validation data set. This is necessary, and we need to form consortia, and work together to achieve this.
Yes, also to minimize the mistakes in these countries where there are not a lot of data, there are some artificial intelligence techniques to small data. No, there are some techniques that can be used when you have small data. So probably it's an approach to make models in this kind of countries also.
Yes, completely agree. So the next question is from India. There is somebody who would like to know the legal and ethical issues of feeding the data, especially CLSI UCAST guidelines to open platforms like ChatGPT.
Oh yes, good question. Thanks a lot. So I consider UCAST as an open source because you can download it. And the thing is, I mean, it's really on the website. And it's not mentioned that this is a license, that I need a special license or anything. With CLSI, it's very different. There you pay to access these documents, and I would be careful with uploading certain licensed documents. And the same is actually true if you download publications from journals. I mean, if this is beyond the paywall, I would advise not to share this with an AI and then ask for a summary. If this is open source, and many journals nowadays have open source, like open science policies, so that the articles can be downloaded, then it's a different thing. Always ask yourself if it's sensitive information you share, and then I think that's I think that's a very important first question. Thank you for this comment.
Yes, thank you for the clear answer. So the next question is for Javier. What type of models, algorithms are you using to predict the bacteria profiles? So basically, what is the input for your app? And I mean, I assume that there is some confidentiality there, but maybe some vague explanation.
Okay, we have some confidential information. No, we can give you the exact model that we use, but I can give you some variables that we take into account to train the model and to make the prediction. No? And some of these things are always demographics of patients, for example, a hospital where it is admitted, region, or for example, hospital work. This kind of variables have a lot of impact in the resistance of the bacteria and in the prediction of the model. But I can tell you, and unfortunately, I can tell you the model exactly that we use because it's protected with industrial property.
Can you tell the input? So what do the doctors need to enter in the app, for example?
Yes, they have to enter the number of history of the medical record of the patient, because it's going to see previous culture of the patient, hospital wards, demographics, and a bit more data, but not a lot of data, because the model we think that has to be easy to deploy. So if we take into account 100 variables or inputs that the doctor has to put into the model to work, we know that it's not going to be used in hospitals. No, so we only take into account a little amount of variables.
But this then takes a lot of time for the doctors to enter all this data, right? Is it?
Yes, they take less than half a minute. And in fact, we are working to integrate this in laboratory information systems. Okay, we have 2 agreements with the most important developers of laboratory information systems in Europe to integrate this software in laboratory information system. In this way, doctors don't have to make the inputs into the software. Automatically, these inputs are put it in the software through the laboratory information system or the medical electronic records.
Yes.
But they are not lot of inputs.
Okay. There are a lot of questions now suddenly running in, so I try to go quickly over a couple of next ones. So there is a question where we can get hands-on training on this, because as Professor Adrian said, that in the next 10 years, the AI will overcome the already available procedure.
Yeah, I think the younger generation, they will have it in their curricula, because many universities now change this. But I totally understand that if you're a more seasoned microbiologist, it's very hard to keep up with the development. So my recommendation are 2 things. First of all, I think there's many seminars at the moment, you know, where you can listen to recorded talks, etc. Some of the programs are really structured. If I can mention this here, ESCMID has, we did a workshop at ESCMID for an AI workshop, and there we recorded all the talks. So if you're an ESCMID member, you can, for example, over a professional society access some of these talks. And then I think that the second best thing to do is simply play around with it. Like be your inner child, open a chatbot account and try it out and see, what works and what does not work for you. I think self-educate at the moment, I think, is a very important step, and be curious.
Yes, I also think that it's important to work and to be open with engineers, informatic engineers, data scientists, etc., and incorporate this kind of profiles in the hospitals, in the research groups. I think that is essential at this moment.
Yes, thank you. Another question for the IAST app is how is it different compared to freely available apps, like the
compared to free available softwares?
Free available apps like Antibiogo. So how is it different compared to that?
Okay. No, it's totally different to Antibiogo, because Antibiogo is something, as I know, that helps to interpret antibiograms. So you give an image of an antibiograms and it interprets antibiograms. No, we don't work with antibiograms. We train or parameterize or refine the model with antibiograms, but we give direct recommendation to prescribers. So our tool, the final user of our tool is not the microbiologist, is the prescriber, antibiotic prescriber. And at this moment, I think, as far as we know, this is the first product with CE mark aimed to help antibiotic prescription guided by artificial intelligence.
Yeah. Another question: in conflict and crisis zones where surveillance and laboratory capacity are limited, how can genomic tools like resistome and mobilome analysis be realistically applied to track the spread of AMR pathogens such as Staph aureus? Again, a question for both of you.
Yeah, the question is, if in a very resource limited situation, if you really need an expensive, fancy technology, to be honest. I mean, the point is always, you want to be effective and actionable. And I would go from simple things like, you know, agar plates and growing bacteria, and then, for example, use an AI to identify bacteria based on their morphological criteria, as an example. Or if you don't have experts who can analyze microscopic images, nowadays you can use your smartphone on the microscope and, for example, identify the bacteria beyond it. And then you can use a cloud, for example. But genome sequencing in an extremely resource-limited situation, I'm not sure if this should be your top priority, to be honest, because the value you generate for, you know, the masses is very limited because it's such an expensive technology. I'm not sure if I would go into this direction. I don't know how others see that, but yeah.
Javier, do you want to add something to this, or?
No, I agree with Adrian.
So we are almost running out of time. Maybe I can ask one final question. How do we use AI to predict susceptibility to new antibiotics where there is likely to be few resistant isolates in any data set? Is a question in the chat.
That's interesting. I think that probably there are some groups that are working in this, and they have a different approach. They analyze the molecules, so they can predict that similar molecules are hydrolyzed by some beta-lactamases, for example. So if this structure is similar to this one, probably is going to be the bacteria are going to develop resistance soon. No? And I think that there are some groups that are working in this, analyzing the structure of molecules to predict how is going to be the resistance.
Yeah, I agree. And also, of course, one could consider doing some evolutionary experiments in the lab as an alternative approach, of course.
Yeah, that's interesting. Yes.
And work with, for example, I mean, very rarely you have completely new classes of antibiotics. So often it's modifications, and then you can also simulate that. I mean, there are very interesting approaches in drug screening on how to develop new antibiotics. And you can also reverse this information. So if you're interested, graph neural networks are here the technology which are currently used for this kind of work.
Okay, Victor told me that we are allowed to ask some more questions. Okay, maybe this one: different mechanisms are involved in conferring resistance to a particular antibiotic. Whether AI will consider all possible mechanisms in predicting the resistance, can MALDI-TOF incorporate all the mechanisms for prediction? We shortly touched up on it, but maybe a small conclusion. Adrian, for example.
Can you quickly repeat the question?
So if you can detect all different resistance mechanisms with AI.
If there's a tool available to do that, or?
In general, can MALDI-TOF, for example, incorporate all the mechanisms for prediction? Or will there always be a technical limitation?
There's always an issue. I mean, the issue is efflux pumps, as always, because efflux pump activity, you also, just by, you know, the thing is, if you detect a gene, for example, with a genotypic S.
Oh.
Adrian is not here now.
But I agree with his point. So I think the conclusion is that for some specific resistance mechanisms, AR Malvitov predictions are not ready yet, or maybe might never be.
Yes, I agree.
Okay. Unfortunately, Adrian seems to have fallen off.
Okay, Victor, I went through the latest questions, and if I got it right, most of them have been answered in some way. I hope I did not forget anything, but maybe these can still be asked via another way. I'm not sure.
Yes, we can have written responses from the speakers if they have the time to do so, and we can post these on the Revive website.
Perfect. Then I would really want to thank the speakers for the great presentations and the discussion. Victor, you also for organizing the interesting webinar. I guess you will have some final words to say.
Yep, for sure. So yeah, thank you, Margo, for moderating today. And of course, thank you to Javier and Adrian for your presentations. This was an excellent webinar, and we've had a lot of engagement from around the world. So thanks a lot for that. So the next Revive webinar will be announced very soon. You can keep an eye on our website, revive.godp.org/webinars, to keep up to date on that. And also to our newsletter, where we'll be able to inform you all about that. So for those of you that are new to the Revive webinars, you can see that update over there, and you can also find our recordings on the website as well after the webinar. So another announcement that we would like to share is from PACE, that's the Pathways to Antimicrobial Clinical Efficacy. So they are having a funding round for projects that are developing new antibacterial treatments. And you can submit your proposal to be considered for this by 5th November. And you can find out more about this on their website via this QR code here. So that will be all from us. So thanks everybody for joining us today, and be sure to join us for future webinars, and please do let your network know about these webinars that we hold at GodP. And also, if you're new to us, and also for all of you joining, please do fill in the survey afterwards to let us know what you thought about these webinars and to advise us for future ones as well. Thank you all, and goodbye.
Thank you. Bye-bye.
Thank you very much. It was a pleasure.
Thank you. Bye-bye. Have a good day.
Bye.